even during COVID, we even did, telehealth or virtual services for a certain period of time when everything was unsure. Nowadays, there are more centers offering like an arm of treatment with virtual outpatient services that include, whether it's IOP or OP, and doing their individuals via Zoom, their physician visits via Zoom, and then they can live anywhere, whether they're at home and sober living.
If you look back at 2020, 2021, there was an explosion in substance abuse and alcoholism. Alcoholism in particular, if I recall correctly. I mean, people were isolated. All of a sudden, they're not going to work. And it was, I think the dynamic really changed. I'll just call it what it is. Insurance companies were the ones that really drove home like, hey, you can do this virtually now.
Where I draw a hard issue with the whole virtual therapy when it comes to substance abuse, there is way too much margin for error. I like what you said, T, about completing 30 days or completing 60 days. And then as part of your aftercare plan, seeing somebody virtually. I love that. I think that's totally fine because you have a solid foundation. But here we are, Real Recovery Talk. I am your host, Tom Conrad. In today's episode, we've got Benjamin B.
Yes, sirree.
And we got Dr. T.
Hello, hello.
First things first, thank you for tuning in on the podcast app, whichever one that you choose to use. And thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you could always reach us info@realrecoverytalk.com. And again, it's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message and also tell you to join our Facebook support group that Ben has so graciously undertaken and is building that up and getting engaged in the comments and so on and so forth.
Yeah, I like seeing all those comments. I think I mentioned that yesterday when we recorded, didn't I?
Yeah.
Yeah, the comments are fun to watch.
Yeah, so you can go onto Facebook and just type in Real Recovery Talk. So there's a Facebook page, and then there's the Facebook support group.
Yeah, you have to ask to be invited, and I'll see a little notification come up, and I'll say accept.
Well, they have to put their
accepting.
email in, right? Don't they have to put their email in?
Oh, maybe.
Yes.
We need to, yeah. That's the only way you're getting in, is if we get your email. So then we can start spamming you. Just kidding. Just kidding. We won't spam you.
The newsletter was pretty good.
Yeah. So basically, it's a way for us to get your email so we can send you the newsletters that we're doing. And in the newsletters, you have the episodes of the previous week and a little description of the episodes and stuff like that. And yeah, it's kind of a new venture that we're going into. There's actually like structure behind what we're doing, thanks to Dr. T.
Yeah, I was actually gonna say, have we even like talked about the fact that we are getting more organized? Well, Dr. T is getting us more organized.
All right, so I'll give a quick backstory on this.
Tom does not know how to use a calendar. That's about all you need to know.
Very true. Dr. Tambini said, look, you guys are doing very good with the podcast. I see a lot of potential with this. I don't think that you guys are operating at your fullest potential in a nice way. That's what she said. And I'm like, well, I agree. And so we brought her on, and for multiple reasons, but one of the big reasons is that to have the medical side, which obviously we discussed, and to have organization amongst Ben and I, and to really help us kind of streamline things. And I'll tell you what, you've done a phenomenal job.
Oh, thank you. We're trying, there's a lot that goes in behind the scenes.
Tom needs to be managed. He's the big portion of the a lot.
Do you think that's true?
But it wasn't very difficult, It's like being in a relationship.
Yeah, I mean, I think you just have to tell me what I need to do.
Yeah, and you're really good about asking, hey, what do we need to do? You're a very good communicator with me, at least.
Yeah.
I would say.
Yeah. See, there you go.
Well, I think in this may be a little off topic, but like any business or anything like that, any organization, there's always the person with all the ideas. That's kind of like you. You come up with these ideas, but then really you need people to execute them.
Yes.
Like, I'm not the come up with ideas guy. Like, I'll just sit in my status quo and I need somebody to like say, hey, let's do this harebrained idea. And then like I kind of get stuck in it and roll with it. Like, but you need like someone in your role, someone in Dr. T's. You need that dynamic.
Yeah, we're covering all the bases now. Like, I had the ideas, but no execution because I can't be organized and do the things that need to be done.
Referred to as flight of ideas.
Yes.
You come up with a lot of stuff.
And they're really good ideas.
Yeah. Yeah.
And you guys have been doing this for so long, and you have like such a good foundation, and just people like support systems, even people in recovery, and also in South Florida. You know, it's awesome. So I think it's.
Yeah, I mean, we've really built a good platform, I suppose the best word to use. And, you know, a lot of people listen, and I think we have kind of made our way into experts in this arena, which is good. People all over the country are listening, or all over the world for that matter. But there's always been things that we've missed, you know? And I think the medical side is one of the big ones, you know, and Ben and I have talked about it at length numerous times. And I was always annoyed at the fact of like, we would get into like medical talk and then have to say that stupid disclaimer. By the way, Ben and I are not doctors. Do not take any of this as medical advice. And we don't have to say that now.
Nope.
You know? Well, we do, but you don't. You know, so we could say, you know, give our medical advice and then just say, right T, and you say, yep. And then we're good to go.
You know what is cool is doing this platform also is kind of opened my eyes to how much experience we do have. Mm-hmm. Like through the experiences themselves, like these random topics come up, and then I start thinking back like in time to certain situations, and I'm like, wow, yeah, we've actually seen that, experienced that. And it just kind of really opens up my eyes to like the bigger picture of our journey over. We've both been in the field for over 10 years now. How long have you been in addictions?
About 8 years now.
I mean, but so almost 3 decades between the three of us, like, and from different avenues. Like Tom and I, we were at different treatment centers when we first met. And then Dr. T, you've got experience at all the levels of care. And it's all put together. Like we've covered like all bases, really, from the operational side to client services to doing interventions to the medical to it's all covered.
Yeah. You know, one thing that, and I was talking to Donald about this yesterday, we need to figure out who are the primary listeners. And so the reason I'm bringing this up now is because we are going to be coming out with a form, and this form will be ready over the next probably week to week and a half. And it's going to be a short form that you will fill out, and we'll have you'll know exactly where to find it. But for the people that have been listening, or, you know, whether you're a new listener or have been listening for a long time, we're going to ask that you go and fill out this form, because what that's going to do, it's going to give us a better understanding as to who's listening. Is it a drug addict? Is it an alcoholic? Are you actively drinking? Are you actively using drugs? Are you sober? How long have you been sober, maybe? Or are you family and loved ones? Are you a spouse of a drug addict or an alcoholic? Are you a brother or a sister? Something along those lines. And the reason we're doing that is because it's going to give us a better understanding as to who's listening and what message do we want to really hone in on. And not that I feel like, or that we feel like we've been missing the mark. I think we do a very good job at covering all the bases. But I just think it would be good to know, you know, who the primary listeners are and stuff like that. So when that form is available, you'll be the first to know. It'll probably be realrecoverytalk.com // fill out this form, please. So anyways, what were we going to talk about today?
I think today we were discussing prior doing the benefits, both the pros and cons, I should say, of virtual therapy and maybe continuing care as far as that goes, doing it in person versus doing it virtually. I think it's important for our listeners to understand the differences. Where should we start with that? Should we start talking about the benefits off the bat?
Well, first let's dive into what virtual means.
Good point.
Virtual, in the realm of substance abuse treatment, you have in-person treatment, which is obviously brick and mortar. You come, you sit in front of a therapist, yada, da, da, da. There's a human connection there. Virtual is exactly how it sounds. It's via Zoom, is Skype a thing?
I don't know
anymore?
if Skype's HIPAA compliant. Zoom mainly. I know Kipu has its own HIPAA compliant thing.
Yeah.
DoxyMe is another HIPAA compliant platform.
Yeah, so it's basically, you're able to receive treatment via online. And that's what we're going to discuss.
All right. So let's start with, since obviously COVID hit, whatever it was 4 years ago now, a lot of, even during COVID, we even did, telehealth or virtual services for a certain period of time when everything was unsure. Nowadays, there are more centers offering like an arm of treatment with virtual outpatient services that include, whether it's IOP or OP, and doing their individuals via Zoom, their physician visits via Zoom, and then they can live anywhere, whether they're at home and sober living, just got out of treatment, had to go back to work, and are looking for a different avenue than the traditional in-person, care.
I'm glad that you brought up the origin, actually. I didn't think of that going into this, but COVID was a huge catalyst to this whole thing.
Yes.
And I mean, obviously it had to do with the exposure. People didn't want to be exposed to COVID. The other part of this is, if you look back at 2020, 2021, there was an explosion in substance abuse and alcoholism. Alcoholism in particular, if I recall correctly. I mean, people were isolated. All of a sudden they're not going to work. And it was, I think the dynamic really changed. I'll just call it what it is. Insurance companies were the ones that really drove home like, hey, you can do this virtually now. Because it wasn't really a thing. I don't know that it would have been considered if I'm straightforward, like a best practice to do virtual. And they made a compromise at the time, but then it just kind of stuck, I think.
They couldn't go back on their decision.
Yeah.
Type thing, the insurance companies, because before COVID, even in the medical realm, like certain insurance companies, and Medicare included, wouldn't even reimburse virtual services just for traditional medical stuff, let alone treatment. And then COVID happened, and that's when a lot of insurance companies started, being open to that idea of even allowing it.
I remember probably 5, 6, maybe 7 years ago, there was a company, and I imagine it's still around, SteadyMD. It was an online, or is an online.
It's still around.
Yeah. And from my understanding, they don't work with insurance.
They do not. It's like a concierge, but it's a membership. Like you pay a month to month, and that gives you X amount of visits per month, access to email, text, stuff.
It was a very cool model. Full disclosure, I actually did it for.
Tom tries everything.
He really does. He's the idea guy. We were just talking about this.
Yeah.
Something new. Let me check it
But
out.
I think that helps him with his ideas, because he signs up and then kind of sees
figure out how it works and stuff like that. Well, the reason I did it was because I follow a doctor named Spencer Nadolski. Do you know him?
I knew Julie Fouché, who was into CrossFit, who she started working for them.
Yeah, so kind of in the same realm. You know, he's an athlete, doctor. He's in particular an obesity doctor. And at the time, I was following a lot of his stuff, and just, you know, on Instagram, he's got a lot of followers, and he had signed on with SteadyMD. And you pay $100 a month, and you got a visit, like a half an hour visit with him once a month. And it was a pretty cool model, I thought. I guess the reason that I bring that up is that because there's a benefit to not being within the confines of insurance companies, you know. So when you're able to pay, and as a matter of fact, I just had a conversation with a lady a few hours ago, and she was debating whether or not she should get her son health insurance, and you know, so we went through the whole thing, and I'm like, yeah, listen, you can, if you want your son to come here and you financially are in a position to be able to pay out of pocket, 100%, I would recommend that. And it's not because we're going to make more money. Oftentimes we make less money with, you know, a straight cash pay agreement than we would from an insurance company. Where the benefit is that you don't have the insurance company dictating clinical treatment. Mm-hmm. You know, it allows us to kind of do whatever we want. But anyways, getting back to it, the virtual stuff, when COVID hit and this started becoming more of a regular thing, I found, and this is just my personal opinion, is that the quality of treatment went off a cliff.
So I'm just going to come out with it now. I was like trying to kind of figure out how I was going to express all this, you know, the pros and the cons. I think I'm biased. I'm with you on that. The quality of care went down, and I think a lot of it has to do with qualifying. Like, for instance, if you look at the whole evolution of it, for instance, it was a good thing in the respect, like, say, for instance, my kid gets pink eye. I can jump right on a virtual with an MD, get a prescription real quick, go through the drive-through, not have contact with anybody, not get COVID. However, when it comes to substance abuse in particular, I think it kind of misses the mark in the fact that not seeing someone in person, there's so much that can be missed. Presentation, do they smell like alcohol? You know, we'll just call it what it is. The consistency. Is the person able to show up, right? Because that in itself shows manageability, unmanageability. There's just so many markers that get eliminated by the virtual. And I think we were kind of talking about it a little bit before we started recording, Dr. T, but in particular, we were discussing like the type of people that are probably qualified and would benefit from virtual versus doing it in person. And I hold the opinion, I brought it up. I said, you know, it's probably not so much the real alcoholic, the real drug addict that would get benefits from doing virtual. It's probably more the problem drinker. And then you brought up, like, because you have experience with this, you've done some virtual stuff. Why don't you share the people that you've seen
like that
qualified?
Have done well? I would say the people that should consider doing, you know, virtual outpatient, maybe the people that are have, you know, employment obligations, if they're just not willing to risk that or lose that. The other thing would be, you know, people who have gotten to legal things. Like the people that I've seen been successful are the ones who got caught drinking on the job. Like I have an example would be a gentleman who was a railroad conductor and was caught drinking on the job, and they basically told him treatment or lose your job, but didn't have the means or wanting to go somewhere, so joined like an outpatient program, or like a higher functioning executive, someone who again is not willing to leave their position, whom, you know, has a somewhat stable home life, right? The virtual outpatient, or people who live in areas that are far away. Like let's say they live in, you know, rural Georgia or Alabama or Arkansas or something, where for them to drive or to go somewhere, it's just not feasible. at least they're getting some type of care in that realm. The other thing was for people who did do like an inpatient detox residential for 30 days, and that's all they could take off from work or whatever they were doing. And then they weren't ready to commit to another, 30 days in PHP, 30 days in IOP in person, that they transitioned into like a virtual setting.
Yeah, definitely. I want to touch on the legal part real quick because, and again, this goes back to qualifying. Like we do pre-screens. I always bring up the pre-screens here. Like who fits the bill for, you definitely fill the bill of an alcoholic or a drug addict. Just because you get a DUI doesn't make you an alcoholic. You could not drink all year, go out one night to a friend's birthday party, have a couple too many, drive home, get a DUI, and all of a sudden, you're court ordered to treatment. Now, I would say I don't believe it would be necessity for someone to go to treatment just because they got a DUI. That's not like a marker of alcoholism. Like, is it one of the consequences? Yeah, sure. If you've got like 3 DUIs, chances are you probably got a drinking problem for sure, into alcoholism. But it could be a one-off, and that's the thing. Like, you'd be doing that individual a disservice. You'd be doing the community a disservice of having somebody here. And we were just talking about this the other day with people being court-ordered to AA on the episode that we recorded yesterday. But point is call it what it is. Like, you're just trying to fulfill legal obligations. It can do the trick. But if you're like the real deal alcoholic, there's just, I really feel like getting in person, because one of the things that I saw, let's start with like the detox process, for instance. What I saw a lot, and like I think it was probably 2021, because we field a lot of calls here. People be struggling with alcoholism, and they'd call us and say, "Hey, I did a virtual, and the doctor on the virtual prescribed me a benzo to detox myself." Well, I took those benzos and I kept drinking and doing them simultaneously. And from my position, I'm thinking in my head, talking to this person, well, that's pretty irresponsible of a doctor to be talking to someone who's in active withdrawal from alcoholism. They prescribe them a benzo and expect them to be able to manage them themselves. They need to be in a real detox for medical reasons. They could have a seizure. You throw a benzo in there and they keep drinking, they could die of an overdose. It became, in my opinion, as an addiction professional, irresponsible. And I think even with COVID around at the time, like, people should have been physically going to detox versus, because you saw the same thing with like Suboxone. Now, all over my Facebook is ads for get your Suboxone within 8 hours of this filling out this form,
Too, like on the front end of things as well, what people should ask questions wise, like if someone is considering doing a virtual program, be reminded that, and ask the programs, whatever care, like if you're in Florida and, the virtual program you're in is, let's say, in Texas, that program has to be licensed. Like if you live in Florida, those providers have to be licensed in Florida, right? Because you can't, for a medical professional, it doesn't matter what state you're in. If you don't have a medical license in that state, you're technically not supposed to provide services.
Weren't some of them, because I remember this too, looking back, some of the states were trying to reciprocate with each other, reciprocity.
So there's something called like the medical compact license, and there's 20 plus states. Like I have a compact license, but to still get licensed in each state, you still have to apply with each state.
Gotcha.
So you have to qualify to get that compact license, and then you have to apply to each state individually. So, I assume, again, don't quote me, but that would go for therapists as well. I don't, 100% know the answer to that. So like, that's one thing going into it, the legalities people should ask.
Well, I think that's why you see a lot of these cash pay type agreements, which I don't see anything wrong with. But I do think in terms of virtual, there are certain instances where I think virtual is totally fine. And I think in most instances, virtual would be totally fine. with a platform like SteadyMD. You're not treating drug addiction. You're treating somebody's high blood pressure, their cholesterol, whatever the case is. With therapy, I get it. Like I see a therapist. I see my therapist virtual because he's in Palm City. I'm here in West Palm. I don't want to drive an hour, yada, yada. So I'm like, we could just see each other virtually. Totally fine. I think that's fine because I'm not at risk of overdosing on fentanyl. I'm seeing him as just a therapist. The point that I'm trying to bring up is where I draw a hard issue with the whole virtual therapy when it comes to substance abuse. There is way too much margin for error. I like what you said, T, about completing 30 days or completing 60 days. And then as part of your aftercare plan, seeing somebody virtually. I love that. I think that's totally fine because you have a solid foundation. But if you have somebody, and I know what you were referencing, like the examples and stuff like that, the executives and the people that can't get away and stuff like that, to just do virtual because it's easier and it's more, applicable, or it's the barrier of entry is lower, which I think is why a lot of people do it. To say that it's equal in terms of treatment, it's not. There's a time and place for it. But most times you should go in person because you got that human connection.
I like that you brought up barrier to entry is lower too, because like if we talk about the intervention process, which we talked about, a lot of times interventions, like the hope is that you go in as an interventionist and you get a yes, I'll do whatever right off the bat. A lot of times, and I have to tell families this up front, this might be a process. A lot of times we get a no up front, but what we're doing is we're setting up conditions to get a yes just a little bit down the road, hopefully sooner than later, if you've set up the conditions properly. And I do think that using virtual in some cases, like if you have an individual that refuses treatment,
yeah,
and they're like, well, we got this virtual thing. There may be a point in a case as an interventionist, I might say, oh, hey, you're willing to do that? Let's try that.
Yeah.
Because this is your idea, right? You're willing to do the virtual. I, as the interventionist, I don't think it's going to work for you. But hey, who am I? Prove me wrong. Have them do it. Chances are that in most cases they're not going to succeed just doing virtual, and because we've seen these cases. Going back to pre-screens, I see people all the time in their story. They tell me their history, and they're like, I tried virtual a week before coming to y'all for like 3 weeks, and I just kept drinking the whole time, and I kept showing up to these virtual IOP groups, and I realized it wasn't doing me any good. I needed the full experience. So it could be something that they need to experience, that it doesn't work, and then escalate their treatment intensity.
Let me bring something up here because I think it's necessary. We're not just bashing virtual. I also think that bypassing levels of care is just as bad. How often do we see people that come in, whether our program or any other program, go into inpatient, and they say, yeah, I got hemmed up with a DUI, whatever they mandated. Did I do an outpatient substance abuse treatment, outpatient, or IOP, even for that matter? And so they sit at home and they're responsible to commute to this place 2 or 3 days a week, go to the groups, and then go back home. And it's purely to satisfy the courts. That, in my opinion, is just as bad. And the only reason that I bring that up is because you brought it up in context of virtual IOP. I think IOP in general can be bad for somebody if it's not done at the proper time, the proper place. There's a reason that levels of care are put in order. Detox, residential, PHP, IOP, outpatient, in that order. There are extenuating circumstances for whatever reason that you have to bypass levels of care. We're not talking to you. We're talking to the vast majority of people that, you know, are banging heroin, banging fentanyl, drinking all day, all night, that are just like, oh, I got a DUI. Oh, I'm just going to try IOP. It's like, well, you're bypassing 60 days worth of sobriety. And to think that you're going to be functional is you're fooling yourself.
We see this often too with people that have a treatment history of doing those levels of care previously. We have a gentleman right now that I went and I met him when he was at detox, and he's like, I'm not going to come to your program unless I can go straight to IOP. And I said, well, we're not going to operate that way. I can see the condition that you're in right now. And for you to come straight into IOP would do a disservice. And he kept reiterating, well, I've done PHPs before. What am I going to get out of it? I'm just going to sit in groups, this XYZ. And
I can't stand people like that.
Oh, you love this guy though now.
Do I?
Yeah.
Oh.
Yeah.
Yeah, tell me who it is.
Tom's, just a disclaimer, everyone. Tom's a little grumpy today, so sorry.
But, you know, I took the time to explain to the gentleman, like, hey, we're not here to hold you hostage. Come here, show us what you're bringing to the table, and you won't be in PHP that long. He ends up getting to us. He sees all the value in the experience that, in particular, like our phenomenal therapists have here. You know, we don't have run-of-the-mill therapists. We have, like, all-stars. Okay. And he's like, well, I had been to PHP before, but not a PHP like this. And now he's trying to stay in PHP longer.
Is this person still currently with us?
Yes.
First name?
Older gentleman.
Oh, okay. Yeah. I got it. I know. Okay. Yeah.
Yeah, I spent probably an hour and a half with him at the detox, like, explaining to him why. He's like, but I want to come to you guys, but and I'm like, bro, I don't negotiate with terrorists. Like,
yeah,
I don't want to set you up for failure. It would be unethical. I just don't believe in it. If I see something like, and don't get me wrong, you know, to Tom's point, there is cases where somebody comes in and we sit down with them face to face and we're like, you know what, maybe in this case, we're going to give this a shot. Kind of like the virtual thing I was talking about earlier. Let's give it a shot. But as soon as it shows that it doesn't work,
yeah,
we are going back to what we are,
what we know.
What we know, yeah.
Yeah, but to explain it to maybe families and loved ones who are contemplating, maybe they haven't sent their loved one to treatment yet, you know, from Tom and Ben's side of things, and you guys correct me if I'm wrong, the reason why we favor in person is because the community, right? Like if you're doing virtual IOP, most of the time you're going to be living at home in that same environment, same routine, doing the same things you're doing, surrounded by maybe not so good people. So that's a big thing, right? When we talk about people going away to treatment, it's removing them from that environment, right? So that's one thing. The other thing is with the virtual IOP, that oversight in terms of if you are living in the community housing, sober living, you're not able to get away with things that you can get away with at home. You can't hide things from drugs, alcohol, you know, you're getting randomly UA'd 2 to 3 times a week when you're in person treatment. When you're in virtual, you know, it depends on the facility, but it may be a random UA once a week. And that's done at Quest, where the turnaround time for confirmation on that UA is another week. So there's a lapse of potentially 2 weeks before that person is caught, you know, still using whatever substances that they are using. So the accountability, it's difficult. The other thing I see difficulty with are the groups, right? So I'm on like on a Slack, which is a way of communicating with staff all the time. And it's like, this person's not on, this person doesn't have their camera on, this person said they were going to show up. They're 30 minutes late. They're still at work. So it's a lot more back end stuff too on the staff, but that accountability as well. You know, when you're in person, you're getting taken to your groups, your meetings, there's structure, right? When you're at home, there's not that structure that you get in person. Another thing as well is just that like face-to-face and body language and behaviors, even like from a physician standpoint, but also from a therapist standpoint, group facilitator standpoint. It's really hard to see those things virtually. Not saying that you can, but we're just trying to give everyone the pros and the cons to everything.
The nonverbal indicators. So I start thinking of Ben Harrison. We've had him on our podcast. He's a group facilitator for us, and he's like a wizard at picking up on body language and stuff like that. Part of the group dynamic, Ben will be focused on somebody sharing, deadlocked in the eyes, but he always has out of the corner of his eye, he sees what's going on. And when that person's done sharing, Ben will like come forward on his seat with the head turn and give that person the death stare, like, what's going on over here, based off of body language. You know, and to your point, like if I'm on a screen, you know, I can take off to the bathroom, I can put my head down for a second, do a line, you know, pop back up like nothing's wrong. But a big part of this too is, does the behavior match what's being covered in the groups? You know, because it's really easy for people that have done treatment before, and we'll just call it what it is. Alcoholics and addicts, we're great manipulators. I can sit here and tell you everything that you want to hear if I'm a client, especially virtual. But then as soon as I click off that screen, how's there any way for those professionals to measure what I'm actually applying as far as action goes? And I think that's where there's a big gap, you know, and in my opinion, that's where a lot of even brick and mortar treatment centers fall apart. They have like a really strong clinical team, and then their housing is kind of weak. And you know, they come here, they present great, and the clinical team's like, oh, they're so good, and they're the best client, and they're doing everything they need to do. Here at Rock, that happens too, where, you know, we meet every Monday, our entire team, every single member of our team is sitting in our group room downstairs, going over every single client's case, and clinical will come out and say, oh my God, they're doing so great in therapy. And then Keith, our frontline staff, will be like, dude, this guy's a total jerk at the house and running rampant, and his ADHD is off the charts. And we're able to make those connections because they can come here and they can put on a show.
It's always funny too when you see that, because then clinical, they always want to stand up for their client, you know, and like the techs, or they want to like say the obvious, like, hey, we're with them 167 out of the 168 hours. And, you know, so there are those dynamics that like the therapists will feel a little like they want to advocate for their client. And it's like,
Absolutely.
Well, wait a second. We understand there's a middle ground here. You want to stand up for your client. We want to tell you what's really going on, you know, and the clinicians are very grateful for that, because then they can kind of tailor the treatment.
It's hard not to become biased when, like, you know, if I'm sitting in a one-on-one session with somebody and you get to know them, and let's say they disclose like trauma they've never disclosed this, it's hard not to have like that heart-to-heart connection with somebody. But the opposite can be true as well, where I just want to throw this out there. It goes both ways. Our therapists will be like, oh my gosh, this person's clinical insight's terrible. Doing one-on-ones with them is horrifying. And they just sit there and stare at you, and you can't pull anything out of them. And they want to throw their hands up and say they're not getting anywhere. But then the housing side of it comes through, and they're like, this person's going to meetings. They're meeting with their sponsor.
They're clean. They're organized.
Working on all the relationships. So it goes both ways.
Yeah.
Where not everybody's going to excel in the same areas. Like some people will have great insight in their therapy sessions, and some people won't. Some people, you know, they'll be good at one or the other. Very few are good at both when they come in.
Yeah. Well, that was fun. Mm-hmm. Do you guys feel like we got everything, covered everything? Essentially, virtual is kind of terrible. No, I'm just kidding. I'm kidding. It serves its purpose. But I will say this. I think that if you are going to explore the ideas of virtual therapy in any capacity, or virtual programming in specifically to substance abuse, do your research, contact us. I mean, you could always reach out to us and we'll kind of get a better understanding of the situation and let you know if we think it's a good idea. And just go from there. I mean, it can, and I think we can wrap it up with this. It can work for anybody, you know, like if you're ready to get sober, you can, you don't even need treatment a lot of times. If you're that ready, you don't even need to go to treatment. We just had Nate here yesterday. His episode's not out yet, or maybe I don't know. Tambini's
It's not.
She's going to get all that stuff set, organized. He didn't go to treatment, but he was ready to get sober. So, but if you're kind of on the fence, or if your loved one's on the fence, to think that they're going to go into some sort of virtual programming and get it on the first try, probably not. So if you want to spare yourself some headache, and because when they don't get it, then you're going to beat yourself up. Like, oh, why didn't they get this? They were in treatment. And it's like, no, they weren't. They were sitting behind a computer in their undies with a bowl of cereal, listening to some therapist on the other end. And then there's so many things that can go wrong with that.
I want to use a real example real quick. I know you're trying to be done with the episode, but I did just have and if he's listening, him and I, we had a long discussion yesterday, so I'm not going to say anything that I haven't already said to him. But I have a childhood friend, mid-40s, just went to treatment for the very first time.
Never called
real
me, by the
treatment
way.
center. Never called you. But he ended up doing detox and residential. It took me forever to convince him to do that. And he was like, wow, I had no idea the great experience I was going to have. He loved it. I got on the phone with his discharge coordinator from there. They were trying to convince him to do PHP and IOP to continue. He couldn't due to work reasons. And I understand they were legitimate. He did need to get back to work. And, I told him, hey, man, if there's any way you could pull it off and do this PHP in person, that's the way to go. And he did consider it for a few days and was trying to work out the kinks. And financially, he just couldn't pull it off. But he did smoke weed. And he's a pretty open book, honest guy, but he is actually, after smoking the weed, now enrolling in their virtual IOP with this program rather than doing the in-person. But I'm wondering, we didn't discuss this part, but, is he going to tell them that he smoked weed?
No, probably. Why would he?
Knowing him, he's pretty honest and open-minded.
I know I sure wouldn't.
But most people wouldn't.
Yeah.
He's one of them guys that loves telling the truth.
Oh, good.
But
that's good for him.
Yeah, but at the same time, right there, perfect example of got out of sight. I believe he needed longer in-person experience. And
there are those people that tell the truth, and they tell the truth because oftentimes there's a reward on the other end. Just so as long as you tell the truth, Ben, everything's going to be okay.
I agree with you there, and that's something we are going to be talking about because I picked up on that.
Yeah. T, anything else?
No, I think we did a good job.
Yeah. One thing you need to work on?
What?
Speaking up.
About what?
No, your voice.
Oh.
Yes.
Sorry.
There you go. Yeah.
She does a great job.
I know that.
Thank you, Ben.
Yeah.
I
Don't take
think
it
Tom is
personal.
just in a bad mood today, guys.
I'm not in a bad
I'm so
mood.
sorry.
You're so critical, Tom.
I don't know what it is. You just have you have a soft voice. That's all. Sheesh.
It's nice for the clients and welcoming.
Soothing.
You should put the headphones on because I'm like,
Oh, dude.
I'm kidding. I'm kidding. That was it. This is fun.
He does crack himself
We need
up.
to clip all of these excerpts today of Tom's crankiness into one Instagram reel.
I
And
know
it
what,
would
though?
be great.
His crankiness is endearing. It's fun. You're the only one around here that, with your personality, you can be cranky and people are like, it's cute. You know what I mean?
Oh, my crankiness is cute. You heard it here first. All right. That is it for this episode of Real Recovery Talk. Thank you for tuning in. In the end, if you have any comments, questions, or concerns, you could always reach us info@realrecoverytalk.com. Again, that's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message and join our Facebook group. That is it. We will see y'all later.